right. Yep. I can see your slides now.
Is it a slide version or?
Yeah, it's a full screen, so you're good. We'll give a minute or two still. And
Absolutely.
are you okay if we record the session?
Yeah, I think it's a wonderful idea. We can obviously share the videos afterwards as well.
Yeah, I see a little bit of myself on the screen if you want to move that off.
Oh,
Perfect.
better?
Yeah.
Now, is that are these recordings going to be available at some point somewhere or?
Yeah, even your recording from EC3 is available on YouTube. I can send it to you after.
No, I'm just saying like if the patients do want to know like what they're rather than like going through, they can just access these videos online, right?
Yeah, exactly.
Mhm.
Yeah, I think we lost 2 people, but maybe they're coming back. I hope. Anyways, let's give another minute or 2.
Oh, yeah.
And how long is your presentation?
Well, it's only about like 25, 30 slides.
Yeah. Oh, okay.
Some of them are just pictures. Some of them are very small.
Yeah, sounds good.
Let me read. Yeah, about 30 slides. No, I lied. 35 slides. Yeah, it's a challenging. I actually told I saw 2 patients yesterday with cholangiocarcinoma, and I did tell them like they can sign on to this to hear more about different strategies.
Yeah. Yeah, I think that more people will come in as they do. So we can get started. And the session is recorded for everyone else that is just joining in now. And it'll be available online on our YouTube. But today we are happy to have Dr. Amandeep Taggar from the Odette Cancer Center at Sunnybrook Hospital in Toronto. He's going to be talking to us about radiation and other local therapies. And I'll just give a brief bio and introduction. So Dr. Taggar is a radiation oncologist at the Odette Cancer Center at Sunnybrook Health Sciences in Toronto. And he specializes in genitourinary and gastrointestinal cancers. He focuses on advanced techniques, including MRI-guided radiotherapy and brachytherapy. And he's also an assistant professor in the Department of Radiation Oncology at the University of Toronto. And his research interests include improving the precision and effectiveness of radiation therapy. He was also a speaker at our recent conference, Meet C3, this past April. Today, he's going to talk to us more about local regional techniques for cholangiocarcinoma. And we do have a question and answer tab at the top that participants can feel free to use and just ask questions while he's talking. There will be a period to go through them afterwards. So that is the agenda for today, and I'm going to pass it off to Dr. Taggar.
Thank you very much, Leonard. Great introduction. I couldn't have said it better. And thank you to C3 for asking me to give this talk. And I truly actually enjoy giving these kinds of discussions. It's more of a discussion with patients and family members, and I see some patient, some audience, some people are in the audience. So feel free to stop at any time and ask questions, raise hands, everything. I suppose, Leonard, you'll be monitoring for any questions, right? The discussion or what I'm going to talk about is about local therapies within the intrahepatic cholangiocarcinoma and extrahepatic cholangiocarcinoma state. When I say local therapies, it's everything other than radiation and chemotherapy, essentially. Sorry, everything other than surgery and chemotherapy, right? So let's start with that. What's our learning objectives? We want to perhaps focus on radiation, and that's my disclosure. I am a radiation oncologist. I treat patients with radiotherapy. So we will talk about a little bit of role of radiotherapy in cancers of the bile ducts, generally intrahepatic and extrahepatic, and some hilar cancers. It is one of the most established treatments within the space of cancer treatment in general. So we see 3 pillars of treatment in cancer: surgery, systemic therapy, and radiation. So those three pillars are generally important to understand. I had paged a physician who just called me back. We'll talk about a bit of role of brachytherapy, which is one of the techniques that I use in managing cancer patients. I use it for bile duct cancers for sure. I use it in prostate cancer. I used to treat gynecological cancers. Brachytherapy was used in that. I often employ brachytherapy in rectal cancers and also some esophageal cancers. So it's a very variable technique. And we also certainly talk about multiple other local treatments such as TASE, TARE, Y90 has been now in the forefront. HAPE, which is the hepatic arterial infusion pump. And of course, one of the hottest topics everybody talks about is histotripsy. In fact, one of the titles that Leonard gave me, it was histotripsy and other local therapies. I actually changed it to the radiation and other local therapies. So we'll say why. So just to give you a little bit of understanding of when you come to the physician and we generally patients will hear the word cancer and I learn from my patients and family members and my own personal family members outside of the medical community is they hear cancer and it's lumped into all one disease. In fact, cancer of every organ is a very different disease. Cancer within the same organ could be two different cancers. And the cholangiocarcinoma is all lumped into one term. In fact, it could be multiple different areas along the bile duct system. So here we have an illustration. This is a liver, sits on the right side of our body, just below the rib cage or under the rib cage. And within the liver, we have these tiny little ducts that collect bilirubin that's produced by the liver. And that bilirubin then percolates down these tiny little ducts, gets collected into bigger ducts, and then goes into even bigger duct. And eventually, they all come together to make common hepatic duct. So this one is coming from the left side. So this is the left side of the liver. This is coming from the right side. They come together, make a common hepatic duct, and this area is called hilum or the hyla. Most of the time, the bilirubin gets stored or bile gets stored in the gallbladder. When you eat, especially eat fatty food, some triggers happen from the stomach to the duodenum, and then bile is released from the gallbladder. This little area is called cystic duct. Then it connects to the common hepatic duct, and this is what we call common bile duct when everything comes together as a one duct. And over here, then it connects to the duodenum and the bile is released for digestion. It aids in digestion. So the cancer can happen anywhere along this system, essentially. When the tumor develops outside of the liver into this common hepatic duct, or perhaps actually further beyond, it's called in extrahepatic cholangiocarcinoma. It's outside of the liver. This connection between the left and the right is essentially outside of the liver. And even then, it's divided into two sections. If the cancer tumor happens to happen in the common hepatic duct area near the hilum, it's called hilar cholangiocarcinoma. So you may have heard the terms, it's type 1, type 2, type 3, type 4, and all depends on how large the tumor is along this section. Is it going to the left side? Is it going to the right side? Is it going to the both sides along? So that's the type 1, 2, 3, 4 types of hilar cholangiocarcinoma. If the tumor happens to happen outside of this, beyond this connection between the common hepatic duct and cystic duct, it's extrahepatic because it's within the common bile duct. Now, there's another patients that I get referred to is if the cancer or the tumor occurs right at the muscle that controls this bile going into the duodenum called ampulla. That's a tricky one. Some people call it ampullary cancer on its own. Some call it hepatobiliary, but that's also part of the biliary duct system. The rest of the bile ducts are within the liver, and those tumors are called intrahepatic cholangiocarcinoma. So intrahepatic cholangiocarcinoma is relatively rare. It's 750 cases per year in Canada, and combined hilar and extrahepatic cholangiocarcinoma is also even more rare. It doesn't even have its own category in our Canadian system. It's lumped in with other GI category, and oftentimes it's about 1,500 cases per year. This is from one of the websites. Duke University had published this paper, and they had this very nice cartoon that in terms of treatments, local, regional, and systemic treatments, what you could do potentially. So obviously, if the tumor, as it occurs into either in the bile duct, intrahepatic or extrahepatic, spreads somewhere else, you can certainly use. You have to think about systemic therapies as your primary treatment. If the tumor is somewhere in between the bile ducts, maybe some lymph nodes, there's some regional areas, you can think of regional therapies such as embolization, hepatic arterial infusion pump, perhaps transplant. And we talk about what the indications of transplant are in a different talk, because we're not talking about in this and maybe radiation. And if it is very localized, you can think of surgery as the primary treatment, either removal of half of the liver or removal of segment of the liver, or just one small component, embolization, radiation, or any other form of ablation where you can essentially kill just the cancer cells and perhaps some surrounding tissue and spare the rest of the liver. The idea with the local treatment is you're trying to avoid all the toxicities that you may get from more systemic therapies. So what are non-surgical liver-directed therapies, especially if, so going back, surgery. In any of the cholangiocarcinoma, only about 25% patients are surgically resectable, right? So we have to think about that. Only up to 1 out of 4 patients may be able to undergo surgery. And what happens if you don't get surgery? What other non-surgical liver-directed therapies are available? One of the first ones that comes to my mind is our mind is often radiation, because remember, there are 3 pillars of cancer treatment: surgery, chemotherapy, and radiation. But there's certainly other techniques, especially in the liver, where our partners in interventional radiology have developed ways to deliver some kind of ablative or cytotoxic treatments right into the tumor. And some of these are called TACE, which is transarterial chemoembolization. So that's what TACE stands for. Or TARE, transarterial radioembolization. All of this is just using the radiation or some kind of radioisotope. Especially in our case, it's Y90, but we often talk about. Or HAPE, hepatic arterial infusion pump. So you're actually putting some kind of mechanism so that chemotherapy or some drug can be delivered directly to the liver. Other things such as thermal ablation, meaning you're using heat to kill the cancer cells, or histotripsy, which is ultrasound waves, and we'll talk about that as well. First, let's say conventional radiation and chemotherapy. There's a number of trials. I'm not going to go through it in the past, and these trials are published in 2013, or these studies, but these were done in the 80s and 90s and even early 2000s, where the physicians and the investigators had tried to deliver some radiation. Generally, that radiation is typically 50 gray or 60 gray. It's delivered slowly in a small fraction of that dose per day in 25 to 30 days. Patients may receive some chemotherapy, because we believe there are some chemotherapies that sensitizes the cells to radiation. So these were delivered and done long ago, and patients' median survival in these scenarios were variable, somewhere between 9 to 22 months. So when we talk about median survival, one of the things I get asked, like, what is survival? Now, median survival is, I wish I can just annotate here. I think I can. Median survival is often we talk about is like if you have a curve that looks like this, and at the bottom is time. And the curve often, we believe, hopefully will look like this. And this is time on this time, and percentage of people that are alive. The median survival is right here, where perhaps half of the people are alive. Some people may live longer, some people may live shorter. So that's what we talk about in our uh, talks. And when you hear your physician go sitting in an interview room and asking a question, we're talking about an average. We don't know what an individual patient's life is going to be. They may end up all the way down here, which is a tail. They may end up on this side, but that's what the median survival is. And a lot of studies that look at the new drugs, targeted drugs, we often talk about that median survival as well. So now let me get my pen and try to erase that, and I've lost it now. Here. Erase all of that. There is certainly interest in trying to see if we can increase the radiation dose. We figured that can we kill more cancer cells by increasing the radiation dose instead of that 50 or 60 units? And by killing those more cells, can we induce better survival? So certainly there's trials from MD Anderson, especially they were the leaders even in early 2000s, where they started to give very high radiation dose and called it ablative radiotherapy. That means biologically effective radiation dose that was delivered to the tumor was 80 gray. You often hear about 50 gray or 60 gray now. And they did find that certainly patients' median overall survival improved in their studies that they did. The biggest critique is a lot of these were retrospective studies, so there's a selection bias. So a physician may only select patients that are doing well in order to put them on the study rather than all comers. So that's one of the critiques, but still, it's something to remember that if you can safely deliver high dose of radiation, you can perhaps improve the survival. And I have firsthand experience that if I can safely deliver high dose of radiation, this was a patient of mine. With permission, I'm using the pictures. 67-year-old gentleman who had a very, very large intrahepatic cholangiocarcinoma. So now, if you believe me, and I can try to show you that underneath this is a very large tumor that extended into the bile duct. And this image is a slice along like this. This image is sliced along like this. So we're looking at liver directly as if you're looking at me right here. This image is a slice straight. I was able to deliver this amount of radiation, 67.5 gray, in 15 treatments rather than 25 or 30. So we shortened the time frame to only 3 weeks, and biological effective dose was 97 gray, fairly higher than 80 gray that we want to deliver. And we saw dramatic improvement. And here's this gentleman's tumor back in July 2024. It was, let's say, it was this big. He spent quite a long time trying to see what can be done or getting onto chemotherapy, but unfortunately, bilirubin was very high, and he couldn't get chemotherapy. Here's a bile duct. In fact, it's supposed to look very small, but it looks really big because it was tumor inside the bile duct. July, August, September, October, November, 4 months later, the tumor only got bigger without any treatment because we were trying to drain. Now there's tumor in the bile duct. Looking straight head on, the tumor got really big, like this big now, compared to what it was just on the top panel. Our hospital tried to put drain, but the bile duct got even bigger. The drain was just not draining. So we delivered the radiation that I just showed you in November, and by January 26th, this is the size of the tumor now, the exact same tumor. So I'm trying to show you the exact location of the image, top to bottom. Here's the tumor now looking straight head on, and here's the bile duct. Compared to this one, we don't see the tumor in the bile duct anymore because it all shrunk down and went back out, and the bilirubin started to improve. And this is what the bilirubin looks like. Just when the treatment was started, it was fairly high in the 200s, 234, without doing any other intervention. By the time I took these pictures in January, the bilirubin was 46, and he was able to start the chemotherapy. So that's a strategy we can employ in some of these local, very large intrahepatic cholangiocarcinomas. And primarily because this is the type of cancer not eligible for many other strategies. Can we not do this for everybody? We've tried to do it in a phase 3. One of the ways to bring this treatment into forefront in radiation oncology, we often believe that we have to show it in a randomized phase 3 trial. There's been a number of trials we just haven't been able to accrue because there's not enough patients, or unfortunately patients pass away or they become ineligible while they're getting. So there's few trials. NRG is our national group in the US and North America. They tried a randomized trial, did not work. Or terminated due to poor accrual. And then there's a China trial with 32 patients completed, but we don't have results that yet. I've been trying to propose that we should perhaps move along this trial. Maybe I'll work with Leonard at some point, and through C3, maybe we can advance this with some support, that perhaps we should be looking into able to proceed chemotherapy or randomize patients to get ablative therapy. And so we can talk about that. There are certainly other ways to deliver radiation in the intrahepatic cholangiocarcinoma space. One of the ways is interstitial brachytherapy. This is routinely done in Germany. This is one of the pictures from my colleague Stephanie Corradini. She does interstitial brachytherapy for metastases and HCC and intrahepatic cholangiocarcinoma, where you just put a needle through here, it goes directly into the tumor, and that needle carries the seed of radiation, radioactive nuclide, and you deliver very, very, very high dose of radiation. The benefit of this is we don't think of there's an heat sink like RFA or other kind of local techniques. For RFA, we have to think if it's close to the blood vessels, they can act as a heat sink, so you're not delivering enough treatment. But brachytherapy doesn't care about that. So you just deliver the radiation as it is. And they have put in multiple needles into very large tumors with good effect. We don't have that available here in Canada at all. In fact, it's very limited. I believe the only people doing are Nepal, Indonesia, Germany, only a few countries. So what about other approaches of intrahepatic cholangiocarcinoma, very localized therapy? And we have to really take advantage of blood supply. Liver has essentially 3 different blood supplies. One comes from artery, like such as this one. This is the artery, that's the aorta, that comes from our heart, the biggest, that supplies rest of the body down. One of the first branches from the aorta as it comes into the belly is hepatic artery. So the blood is supplied by hepatic artery. We also have blood supply to the liver from portal vein. That's all the blood that includes the nutrients that's absorbed by the gut, and then blood goes into the liver. That's how our liver actually synthesizes and does what it needs to do and absorbs the nutrients. Then finally, the blood supply is how it leaves from the liver into the heart through this vena cava or veins, and we have hepatic vein. So there's 3 different blood supplies into that. So what our interventional radiology colleagues utilize is the arterial supply of the blood, because even if you completely block arterial supply to one segment, the liver will continue to gain its blood from the portal vein. Just that's the functionality. And the only thing you have to recognize is if you deliver some chemotherapy agent to some part of the liver, you have to block the vein first. Otherwise, the chemotherapy agent potentially will continue to go into the heart directly. So that's why oftentimes what they do is they will just block one side, they will introduce some kind of catheter and deliver a drug or a radioligand directly in the area. Now they're very sophisticated. They can just do a small segment. They can do 2-3 segments. They can do the entire half of the liver if they're necessary, as long as they can identify a artery that supplies that. And this is very, very helpful for liver cancers, especially hepatocellular carcinoma, because they are very arterial rich, meaning there's lots and lots of arteries. That kind of tumor likes to develop more blood vessels, so it's very effective. Cholangiocarcinoma, on the other hand, has two different forms of how it forms. One is called a infiltrative form. The other is just a solid form. If it's a solid form like this, it works on that. If it's an infiltrative form where the tumor actually starts to creep along the bile ducts, then it may not be as effective. So even though it's the same treatment, it may affect differently in different patients. Overall response rate is somewhere between 10 to 50% when you look at patients who have chemotherapy delivered like this. There are certainly some trials, mostly phase 2 trials. They've used a combination of some chemotherapy going through the IV directly with directly putting chemotherapy into the artery or versus chemotherapy alone. And they found that even though response rate was higher, there was significant more downsizing of the tumor, so the tumor got smaller, and the median progression-free survival increased, and also median overall survival increased. If you recall my overall survival curve, so that's the median average overall survival. So there's some data to support combination of putting directly chemotherapy into the liver and also adding systemic chemotherapy. Going back to my radiation trial schema is that you got to add chemotherapy, because one of the problems is that essentially these kinds of tumors may have already metastasized or spread. Leonard, how are we doing? Any questions so far from? Okay. That gives me a chance to take a sip then. The second type of treatment where our interventional radiology colleagues can deliver directly into the tumor is radioligands, or small, tiny molecules of radioisotopes, meaning they can, the radioactive nuclei, that's the central part of this, can emit some radiation, oftentimes very, very small. It's localized. And Y90 is one of those nucleides, and we can deposit those through the arterial blood supply directly into the tumor. But the response ratio is again different, 6% to 50%, depending on where you look at it. It goes back to what I said. Some of them are infiltrative tumors, don't respond, whereas the mass-forming tumors that are like a big tumor, like a big mass, they respond better because the blood supply goes all around into one. There is a trial that looked again, our standard chemotherapy. I'm sure if you have come across with your family members, you've heard them getting gemcitabine and cisplatin as the backbone chemotherapy. So a lot of it is just, this is the backbone of cholangiocarcinoma trials. Either you combine with radiation or transarterial treatments, or with durvalumab, which most people get, gemcis-durva. Overall response at 3 months was 40%. Median progression-free survival was 14 months. And this is the only trial actually for the TARE where the median overall survival was higher, but it's 22 months. So even though TARE is sort of recommended in some scenarios, but often not done because its overall response is still lower than some of the other therapies. And I don't believe we have TARE as an option for cholangiocarcinoma yet. Right, Leonard? Not in Canada. It's been done in the US, but not in Canada. It's only TARE, or Y90 is only recommended for HCC because of its mass forming and a lot of blood vessels, and metastases if there's a cancer in the liver from colon or mostly colon cancer. Ongoing trials, so certainly because this was a part of the C3 where we were discussing from the ongoing, there's certainly some ongoing trials. Emerald is just completed, I believe, this one. We still haven't had the results, but it was limited to HCC patients. So a lot of these trials are HCC patients. Histotripsy, the buzzword everybody sort of talks about. So, what is histotripsy? All it is they're it is not invasive, meaning there's no um, probes or transarterial wires or any kind of incisions done. So all you're using is focused ultrasound. So this is an ultrasound machine right here that's placed in a water bath. This is all a water bath. The reason it's placed in a water bath, if there's any air between the patient and the ultrasound probe, the ultrasound waves don't transmit as well. So the water bath really acts as a full filler, like a damper all throughout. So the ultrasound waves from this point can go all the way to the target where it needs to go in the liver. So it's a non-invasive, non-thermal, similar to HIFU. You may have heard HIFU as a technique in patients who are prostate cancer, high frequency ultrasound for treatment of prostate cancer. And these waves are focused right to the tumor, very small wave, and this particular uh, area continues to move along this line or down, sort of mechanically emulsifying the tumor. So basically, all you're doing is just breaking down the cells, and they're just dying. Essentially, that's the hope, or eventually they will die because they're broken down. So there was only single trial which made this very popular in Europe, 40 patients. Efficacy was measured with MRI at 36-hour post-procedure, meaning how effective is this treatment? And they deemed that out of 44 tumors that were treated, 95% responded or were emulsified. And so FDA approved this in 2023, but there's an ongoing US version of this trial, which was recently just updated. Just in December, like last week, this update came out. So 19 patients with HCC and 23 patients with metastatic disease. So none of them had cholangiocarcinoma, the update. So it's very good to clear. And what they respond at the 1-year response rate, control rate was 63%, even though they said at 36 hours, everything was 90%, but in 1 year, control rate, meaning the cancer started to go around it, was in only 60% or so. And the overall survival that they reported at 1 year was only 73%. So some of the treatments that we currently have for HCC and other metastatic disease are much better than this response rate. So I think this is still an ongoing research, even in the area where they've tested already. It doesn't really have a lot of data in, I should say, published data in cholangiocarcinoma. Perhaps there are people doing it in states, and certainly, but we just don't have that data to suggest, hey, this works, you should go do it. And this was just public. So that's essentially the breadth of histotripsy literature that's available to us, other than pamphlets or like ads and other things. So certainly, I'm happy to talk more, but I don't think it's worth more than this much discussion. Moving forward, hepatic artery infusion pump. This is also a technique where a surgeon actually, this is a surgical technique rather than interventional. A surgeon actually implants a pump on the left side, oftentimes, of your belly, just under the belly fat or inside. And then there's a little a catheter that they insert into the artery that goes into the liver. And perhaps they can put it just in the main artery, or they try to put it in one of the smaller arteries, one side versus the other. And then they can instill chemotherapy. This pump is actually just a little reservoir. So you have to go again and again and get it filled with the chemotherapy, where you deliver the chemotherapy directly into the area. Most common indication so far is metastasis. When the colon or rectal cancer go to the liver, that's the most common indication, and it's been done in the US. It's been done here at Sunnybrook as being one of the only sites in Canada that does this for liver metastases. There's certainly emerging data, and some people in the US are doing it for intrahepatic cholangiocarcinoma, not extrahepatic. It's resectable. Dr. Paul Nicholas from our institution we were just discussing this morning. Perhaps that's one of the other trials to bring to Canada for this intrahepatic cholangiocarcinoma do it here. But it's going to be in trial setting as well, or at least feasibility trial setting. So perhaps we'll have some more data from Canadian perspective in next few years, if we can get it started. So not done for cholangiocarcinoma in Canada. Some centers, perhaps in Seattle and maybe down in LA, are doing it for cholangiocarcinoma unresectable, but limited. Okay. So making a cancer treatment decision becomes so hard when you have all these options. But that's just for intrahepatic. For extrahepatic or hilar cholangiocarcinoma is even more challenging. If the cancer occurs right here, the only way to remove it surgically is transplant, because you can't just, I tell my patients when they see me, think of it as a tree. That's why C3 has a pin. It looks like a biliary tree. People ask me when I wear it, like, oh, what is that? I'm like, it's a tree. And then you have to, so think of it, you can't, when the trunk of the tree separates into two, you can't just say, I'm going to cut here, cut here, cut here, and put everything back together. You have to essentially remove the entire tree from the top and get a new transplant teeth. That's why hilar cholangiocarcinoma, the only surgery is transplantation. And it's very rare. It's been done so far. For extrahepatic cholangiocarcinoma, that's outside, you can generally do Whipple procedures, the same thing they do for pancreas cancer. So that's also an extensive surgery that requires removal of the gallbladder, connection of this to a new duodenum or a small bile. So it's a big procedure. And this happens perhaps only in about less than 1 out of 5 or 1 out of 6 patients in these kinds of surgeries. Unresectable cancer, which doesn't have any treatment, either in chemo or any other, is perhaps only median survival is 3 months or so. But often these patients can get some systemic therapy, which is chemotherapy, often Gemcitabine, which has become the mainstay. The median survival can be about 10 to 11 months. And we have other strategies, because many of these patients, because what happens when you put a tumor here in the bile duct or here, it blocks and patients become jaundiced. This is the most common presentation, that the patients come to emergency department in middle of night or over the weekend because they're yellow, itchy, urine looks very dark. They feel very tired, sick, can't eat, drink, losing weight. This is an example of a biliary tree. That's one of the things that my colleagues in interventional radiology, or when you go through ERCP, get it done. Here's a little tube that comes from outside of the belly. It goes into one of these small bile ducts, and then from there they can reach the main bile duct, and they inject a little dye, and that dye can go back into all the bile ducts. That tells me that if I inject a dye right here and it goes into everywhere, all those ducts are open. Everything is good. Free flow of the fluid. And technically, it should come down straight into the duodenum in the same fashion with the same caliber. But you see, it abruptly stops right here. The only thing comes down is this tube. So there's a tumor that's blocking the coming of the bilirubin from here. So this is called a cholangiogram. That's how we as physicians and interventional radiologists understand where the tumor is. It's below the hilum into the common bile duct area. So this is what we use sometimes to deliver the treatment, understand what's going on into this hilar or extra hepatic cholangiocarcinomas. What type of treatments are available if surgery is not possible? Conventional radiation, SBRT, you may have heard, and brachytherapy role here is very important. And photodynamic therapy sometimes can be done in these areas. And there's not a lot of data, but maybe 1 or 2 papers about that. Conventional radiation, again, retrospective stuff, meaning like patient selection bias from MD Anderson. If you deliver enough radiation dose with some chemotherapy, you can reach that same overall survival of 12 to 14 months. The median survival is about 18.7 months, even in the best of hands. There was a trial done. It's a randomized trial, phase 2, where people received some chemotherapy with the radiation, with versus just the chemotherapy alone. The primary endpoint was to see progression-free survival, how long patients live without progression of cancer in the locally or somewhere else. 69 patients had were accrued to this trial. Some of them, a majority of them, have that hilar or cholangiocarcinoma. They found that it was about similar, and either you get chemo or radiation. However, local progression was significantly worse in patients who did not receive radiation. So local progression was 16% if you got radiation, 30%, so nearly 1/3, progressed locally. And the issue, if you have local progression, is you block the bile duct again, you get into jaundice and infection again. Even though overall survival, what we in scientific community believe significant or not significant, is not significant. But looking at just the numbers, the overall survival was significantly higher, or at least numerically higher, in patients who received radiation. A lot of my medical oncology colleagues, you may hear that addition of radiation may not be beneficial. But if you're okay to get chemotherapy, considering this might not be a bad option to give radiation, but it is higher dose of radiation. There's some other trials looking at all of this, median survival 15 months, 10 months, 35 months, because these are all selection biases. So I have to always tell patients what's going on. The radiation can be very challenging because lots and lots of critical structures are close by. Here's the bile duct I have outlined right here. Here's the duodenum. So if you're trying to give radiation to the bile duct, all of this duodenum will get radiation. Hence, sometimes you get duodenal bleeding or ulcer. So that's one of the challenges I wanted to point out by showing you this picture. Ongoing trials in this one, there's SBRT's ongoing trial. There's a chemo along in combination with radiation for unresectable cholangiocarcinoma trial. It's still recruiting because there's not enough patients. So role of brachytherapy, some of the local management of patients with hilar and extrahepatic biliary cholangiocarcinoma. This is a protocol that we have at Sunnybrook in Canada. We're the only hospital who's doing this kind of treatment and really providing benefit and quality of life and perhaps improving patients' survival as well. Going back to our problem, what was the problem if you have a cancer in any part of this bile duct? You block the bilirubin coming down, bile coming down. So one of the things, like if you end up going to a local hospital that doesn't perhaps know what's going on, but rightly so, first approach they will do is they will put a camera scope through the mouth into the stomach, into the duodenum, and from there they will introduce some mechanism of putting a stent to open up, let your bile flow normally. So that's the ERCP. They'll often put a plastic stent in here. The problem is you can put a plastic stent, they can start acting as a nidus for infection, or they generally block within a few weeks, or they can, the tumor can continue to grow even when you're getting chemotherapy and they block. Generally, they're open only for 3 months on average, but I think in reality, all I've seen is maybe 2 to 3 weeks. And if you and your family has ever experienced this, you'll tell me, yes, that's true. Every 2 weeks, we're supposed to go, we often ended up in hospital to exchange. They can sometimes put a metal stent that's permanent, but what the research studies have shown is that there's only open for about 140 days, which is also 3 months. So the other approach is that you can put a percutaneous drain, the one I was showing you on that black and white picture of cholangiogram. Using the same approach, you can put metal stents into the biliary train. This is more successful if the tumor is really at the hilum, where the two ducts divide. Percutaneous biliary drain is often permanent. Once you get it done, it's permanent. And quality of life, unfortunately, decreases significantly when you have a tube sticking out of your body that you can't shower properly, you can't bathe, you can't go swimming. And a lot of these patients that I see have these kinds of. It's a significant impact on quality of life. So what is the role of brachytherapy in this particular scenario? And oftentimes it improves quality of life and palliates a lot of symptoms. We do have seen its improvement in overall survival, and we're slowly moving towards using brachytherapy for really patients who may benefit from eradicating this cancer. That's what we mean radical when we combine it with patients who may be getting transplant or some external beam radiation. So in this extrahepatic cholangiocarcinoma space. So one of the first things when we went to our hospital, why we want to do this is looked at all different studies. So this is not a new technique, brachytherapy, unlike histotripsy, or this has been used since 1980s and 90s. So we looked at all studies that have been reported to do intraluminal high dose rate bile duct brachytherapy, and we found 17 studies, a total of 640 patients, not 30 or 40, and 342, so nearly half of them had received brachytherapy. And what we found that just the stents alone, just opening of the stent was extended from 2 to 3 months to 10 months, so that patients can remove this drain and their stents are open for 10 months. Um, and the survival, even overall survival, was 11 or 12 months, similar to what often I tell my patients. If you have most state-of-the-line chemotherapy, gemcitabine, cisplatin, and durvalumab, the overall survival is about 12.4 months in that study, median survival, just with brachytherapy alone. And now I'm not saying brachytherapy is treating all the cancer, but I think what's happening is there, because you're giving brachytherapy and you're making these stents open for much longer, patients are not getting repeated infections, they're not coming into the hospital. A lot of times sepsis is the reason, unfortunately, patients pass away, even if their cancer is being treated or not being treated. So just doing a technique which is perhaps simpler, using the existing route that's a drain, can significantly improve quality of life and survival. So that's one of the ways we convinced our hospital that we need to do this here. And here's a great example of a patient. So again, looking straight coronal view, I can convince you that this is a bile duct. This is right at the hilum. The left side and the right side would go like this. This tumor is extending right from here, from the common, and going into the left side of the patient's bile duct. It's not going to the right. This is looking like a bread slice. That's the liver. This is the portal vein that we talk about, some part of the stomach, kidneys over here. Bile duct is right here. Generally, this is a very small little 2 to 3 millimeter, but it's about 1 centimeter space. So we were able to do the cholangiogram on one side. We can tell that the tumor is sitting right from this space to right here, as there's a filling defect from what we injected. And using that same area, we can place a very special catheter that looks like this directly into the bile duct. Now we can use this special catheter directly into the bile duct for delivering that radiation into the bile duct where the tumor is sitting. And the radiation dose just in and around the tumor is not just 60 or 70 or 80 gray. It could be much higher, 200 to 300% sometimes higher, because it's so close to the radiation source. And here's an example. So if my nominal treatment, we said 500 centigrade, is this yellow, that's sort of yellow line is going right here. That's the 100% of the dose that I want to give. Right in the bile duct is 200%, that purple. And right next to the radiation where the tumor is probably 250, 300%. So we're delivering much higher dose. Essentially, I look at it as sterilizing the whole stent and that area by high dose of radiation. Even if the tumor is at the hilum, we can, at our institution, we can put various stents trying to normalize the way the bile has to flow, so that we can deliver, put in the stents and deliver some radiation and remove these drains, so that patients can have quality of life. And oftentimes these patients may go and have chemotherapy that can extend their life even further, perhaps. So that's the idea behind doing this. Here's a radiation dose again. Yellow is our 100%. That's being delivered all the way around the tumor. This is 200%. Now inside the tumor, right here, where the actual tumor was, we're probably 300 to 400% radiation dose. So we've treated, this was a few months old, we've treated up to about 50 patients now, and we find that the stent failure rate is significantly higher. Stents are open up to 20 months, not just 10 months as I expected, because we're actually doing this in a proper controlled fashion and image guided way. So that's our Sunnybrook technique, and I think that's all I have for local regional therapies for intrahepatic cholangiocarcinoma. More exciting part, extrahepatic, but maybe a less. So I'm going to open it up and stop sharing my screen.
Thank you so much for that wonderful presentation. It was a really good overview of all of the different types of cholangiocarcinoma, and the origin, and with the diagrams so easy to see. And I also have a new understanding of like how to look at those images and what radiation oncologists are also looking at. So thanks for that. We do have some questions. I'll read the one that's in the chat from Holly. So she says, I read and heard that radiation causes scarring that can make resection impossible. So if resection may become possible in the future through chemotherapy, it's maybe better to put off radiation until resection has been deemed totally impossible. So what are your thoughts on that?
Yes, you're correct, and we know that the radiation can induce a lot of fibrosis, which makes a surgeon's job much more challenging, and we've seen that in multiple areas. I deliver treatment for rectal cancer as well, which is most of it is all treated with radiation before surgery, and even in those scenarios, we do know fibrosis and scarring can happen with radiation, but surgeons can successfully remove that. However, the smaller blood vessels they are, the more scarring can happen, and that's what happens perhaps in the liver. There's a lot more scarring, and that just cutting the liver or segment of the liver is more challenging. So by that reason, if a surgeon is even considering resection at some point, I often say we should not do radiation until we say it's completely unresectable by surgeon's assessment. So you're correct. How much challenge a surgeon may have in resection, we don't know. We haven't done a prospective trials to properly study that, is it a challenging or not. In pancreatic cancers, there's been few trials where they've done SBRT, which is the radiation, and then they have gone to surgery. They have been successful in doing surgery, except that it bleeds a little bit more. And that's the main feedback I received from my surgeon.
And just a follow-up question for me. So are surgeons and radiologists, or interventional radiologists, are they in communication whenever a case is being discussed, and that's always like radiation's always part of the discussion?
Yeah, so when we do sit in our MCC, certainly we, as a radiation oncologist, we always are involved and included in the discussion for providing the treatment. Now, that's our practice. Again, it's very institutional driven. I hope that in all the institutions, that's how the treatment decision should be made, by especially having main three pillars of any kind of treatment available: radiation, systemic, which is chemo and surgery, and then in liver cases, interventional radiology as well present in that core group of people to decide. And once you have all those core groups, we're very successful in guiding the patient treatment.
Yeah. Okay. So maybe it is always good for a patient to maybe self-advocate for radiation options, just
to hear it out,
just to make sure. Yeah. Okay. So another question from the chat, Heba is asking, dilation in the bile ducts due to overtreatment by TACE. Can this abnormality be reversed by time when there was no recurrence?
Yeah, generally not. Like if you have a dilatation because of the TACE, that part of the liver often becomes fairly unresponsive. You're essentially killing that part of the liver as well. Some of it can regenerate, and when things regenerate, the blood vessels may not regenerate in the same fashion as originally the liver was made. So you may not have the same sort of blood flow again, even after radiation or TACE or other procedures.
Mhm. And then she also asked for stents, it's not a
Sorry,
great.
like I'm looking at the dilatation of the bile ducts.
Yeah.
So the bile ducts generally dilate because there is a biliary obstruction. If you can remove that obstruction, generally that improves. So because the TACE can often just completely block those bile ducts, you can't really reverse that, unfortunately. So if the parts of the liver are fibrosed and dead, and that's the reason for bile ducts to be enlarged in that area, you can't really reverse that part.
Okay.
As for stents, is it not a great option for the long term, more than a year? So the stents are often used for larger bile ducts, generally in the hilum or in the common hepatic duct or in the common bile duct. It's not used for intrahepatic biliary ducts, so that's very rare to none ever used. It's a great option, but the longer term any kind of foreign body lives in there, there's an increased risk of debris or sludge blocking it. So I often see that as a cause, even if there's no tumor. I have a patient with just sludge as a foreign body. You can have an infection. So there are risks, even though I have patients who have now 3 years out with a stent and they're fine, but there are risks.
I'm gonna skip Ken's question until the end, but Holly just wanted to follow up with radiation and scarring. Would that same be true for liver transplant?
Yes, so there's certainly a trial, or used to be a trial. Now it's a published data as well from Mayo Clinic, where patients underwent radiation and then underwent transplant afterwards. There is increased fibrosis, but you're taking away most of the area that has received radiation in that scenario, rather than leaving anything behind. So the only challenges are technical difficulties of doing the surgery rather than anything after. Sometimes if the area that they reconnect, if had received radiation in the past, there's always risk of stenosis, meaning fibrosis in that area. Sometimes surgeons would say there's a risk of leakage as the connection doesn't get better. So those are the risks, but from the data from the transplant, it appears that you can certainly safely do radiation in many cases in this scenario.
Great. I just wanted to check on the timing for you. Do you have time to go past 2 p.m. or do you
Yeah,
have to?
certainly I can.
Sure, we'll go just a couple more minutes. There was a question in the question and answer tab from John.
Mhm.
So it says that he has bile duct cancer, just where the biliary tree meets the common, had Whipple, and is wearing a biliary drain. He mentions that Dr. Burns, who is a doctor that does histotrypsy treatment in the States, claims ultrasound can't be used for a second treatment. Not sure if it's can't or can, but
Where's the question?
yeah, it's in the question and answer tab, just beside the chat button on the top.
Oh, I don't see that. Maybe I use a
Okay.
different link.
Well, the question is, what do you think of histotrypsy's success rates? Yeah.
Well, like I was just talking about it. It's one of those new techniques, new machines that is being advertised with not a lot of data supporting it. Like I would say like I would have to see more properly done trials, just like we presented a little bit of data on Hope for Liver trial, which was mostly HCC and metastases, not as much as for cholangiocarcinoma. And even in that, at 1 year, and those are formed tumors, circular, not at the anastomosis where the bile duct is connected. And as if I understood the question, his question was like it's recurred at the anastomosis, right?
Yeah, just that's where it is.
Yeah.
Yeah.
So there's not a data for at all for anastomosis, and what happens to when you break up those cells, the chance of completely breaking down and leakage of that area. So one, there's not enough data. Two, theoretically, I think it may actually make things worse.
Yeah, I've heard that it's really not about the size of the tumor. It's really what's mainly important for radiation therapy is the location, just because of all of the important structures and close organs beside it. So many things go into determining what might be the best
And
treatment.
what the bile duct is being connected to is the intestine, and there is really no data, and perhaps it's actually unsafe to use that kind of substance emulsification onto the intestines, because that will cause ulcer, perhaps bleeding, and in fact, that's what I'm saying. It may be a bad idea.
Mhm.
No, I think we've answered all the questions in the chat.
Yeah, that was great. And again, if anyone has any questions about local regional therapies, you can feel free to email c3@ohri.ca or info@cholangio.ca, and I'll send you an email, Dr. Taggar, with all of those questions.
No problem.
There is one more question that I want to respond to just regarding updates on the TIL trial, and that's what the tumor infiltrating lymphocyte trial that the C3 is working hard to get up and running in Canada. I have a meeting with the trial team tomorrow to come up with a public communication just before the end of the year about our status. And yeah, so first of all, the trial will be starting it will be starting recruitment and everything in Montreal, not in Ottawa. Ottawa will come online as a second site sometime in the future, but all efforts are now focused on getting it up and running in Montreal. There are a lot of things that we have to do to get that prepared, including getting the infrastructure and making sure that the products that we're making are safe. And so that's where we are currently. But we'll have an official update before the end of the year, and we'll send it out in our newsletter, and it'll be on our website too. Okay, so thank you so much, Dr. Taggar, for spending your time with us, teaching us about local regional therapies. It was really insightful, and I learned a lot from these sessions. And we will be posting this on our YouTube. And again, thank you all. Happy holidays.
Thanks very much, and thanks everyone. Bye.
All right. Bye.